Okay, welcome everybody. We're going to go ahead and get started. I'm really excited that you guys joined us today. If you could also in the chat, just add your contact information. Welcome to the ECHO session. We are going to be recording this session just for quality and educational purposes. By participating in this session, you're consenting to being recorded. If you'll go ahead and take a minute and rename your profile. ECHO is a huge part of a community of practice. So the more that we know about each other and how to contact each other, the better. That will help our community of practice. We want you guys to be engaged. So asking those questions before and during the didactic session, as well as provide any feedback for those case narratives. Case narratives are a great way for us to learn from each other, hear ideas and others' perspectives, especially in our small breakout sessions. We all have a perspective, how to work with families and how to interact with them. So if you have a case narrative that you want to present, please reach out to us at Project Scope and think about sending that in. On that note, we are talking about families. We're talking about some tough cases. So please make sure that when we are sharing anything, we avoid using any identifiable information. Don't share their names, family members. If you have any questions, reach out to one of us from the Hub team. The Hub members all have an asterisk in front of their names so you could locate them on the chat. As you all are aware, the key components of an ECHO session are really building that community of practice. So sharing our knowledge with everybody, a didactic speaker, as well as a case presentation and feedback. We would love to hear throughout the session, a comment in the chat, either a reflection from the session or one thing that you think you might be adding to your own practice. You can always pre-register for those ECHO sessions at Project Scope at usu.edu. And then the certificate of attendance that we send out after our surveys are completed. I'm going to let Jared talk a minute about the CMEs.
Thanks, Janelle. So quickly, there's two things that we say often about CME that are repeated often, but worth repeating. One, to claim CME from the University of Utah, you do need an account or a profile, so please make sure you set that up. Two, please claim credit today. We'll give out a code, and I'll put it here in the chat. That code is 237195. Again, watch for that in the chat, and then you will receive a separate email with that code. That code is valid through midnight tonight. Once midnight comes, that code has expired and you've missed an opportunity. So please attend to that right away. For those who are seeking nurse contact hours and other kind of credit, you're certainly welcome to claim CME, and most nursing boards, locally and regional, do accept CME hours for their purposes of privileging and licensing and so forth. So please claim those and either research or check with your licensing board about how to apply those to your certifications. Watch for the email from me, and then you're welcome to contact me personally with any questions. Thanks, Gina.
Thanks, Jared. As you guys, if this is your first time or you've attended one of our sessions before, please know that we do have a Canvas site where we put any of the information for the sessions, the recording, and any information about the case studies. So if you have not received an invite for Canvas, you can reach out to Kurt Phillips directly, or you will be also getting another invite after this session. The red cap is the data collection that we use to make informed decisions about how to move forward with our project scope. So there is a survey that will come out after each session within 1 or 2 days. Sometimes those do go to your junk emails, so be sure to check that. Again, just that case narrative, to be able to share information about real life situations, hear from your colleagues about recommendations, and receive valuable intake. It's really exciting, this scope session, that we do have just a wealth of information and two professions or multiple professions coming in. It's great to hear about it. The healthcare perspective is just an amazing perspective that helps us as early childhood or early intervention providers. So hearing that from both perspectives is just, I'm so excited about it this year. So please, if you have a narrative or a case study that you would love to, not necessarily love, but enjoy presenting and hearing feedback about, that would be just amazing. We do have our Facebook and Instagram pages. So if you are a social media fan, please be sure to follow us. We put information on there as well as anything about upcoming presenters. I am just really excited to turn the time and introduce Heidi to share. I guess I cannot do two things at the same time. I was trying to not share my screen and talk. So Heidi is sharing all of her information about the social determinants of health. So I am going to turn it over to Heidi and let her take it away.
Hello, everybody, and thank you for that introduction, Janelle. I'm excited to be with all of you today. I always enjoy interacting with this group and certainly admire this effort. And after I'm done here today, I'm going to go follow you on my social media accounts. I don't think I've done that yet. So I will definitely do that. Let me just get in the right presentation mode here. Okay, are you seeing what I want you to see there, Janelle?
Yes, we are.
Okay, wonderful. So again, thank you for that introduction. Glad to be here. My didactic 30-minute discussion here with you today is about upstream prevention. And I invite you, if you have questions along the way, to drop those in the chat. And I hope to have a good interactive discussion here today. I'll be sharing some research science with you on prevention, as well as some application and some specific stories. So hope this is helpful for all of you today. Just really quick introduction. And I forgot to edit this slide. Last time I gave this presentation, I was Heidi Peterson. I am now Heidi Peterson Dutson. I got married last summer in the midst of COVID and all. So that's a little update on me. I started working in prevention work in 2009, and before that I'd been in the field of business and insurance. Due to some family responsibilities, I had a little break in my working, and then I took a parenting class, and I was so impressed with the science behind the class and its application that I made a career change. And I have been deeply involved in prevention work since then. For a time, I ran a prevention coalition out where I live in Tooele City, worked a lot with the schools and interventions there. And then about 3 years ago, I came to work for the state at the Division of Substance Abuse and Mental Health. I've been able to do some great partnering in suicide prevention, as well as keep up those community. I provide technical assistance for communities in employing prevention efforts throughout their communities. I help to advise and chair the state epidemiology outcomes work group, and sit on the Parents Empowered Advisory Board. So that's just a little bit about me. More important than that, me and my husband have a combined 8 children and 6 grandchildren, and mom and grandma is my favorite role. Really nothing to disclose at this time, but some of our learning objectives that we want to talk about is understand just a little bit of the impact of opioids throughout the state of Utah. And then we're going to talk about some of the history and development of prevention strategies. Where have we been? What do we know now? And when it comes to prevention, how can we operate in a way that makes a difference? We're going to talk within that about risk and protective factors, what they are and how they apply to that. And then I'm going to share a model with you that I just love, that's going to talk about connectedness within our families and communities. That's actually a very preventive measure. And then we'll talk a little bit about how prevention environments and shaping those can be nurtured and implemented by those in recovery. I think those in recovery can be some of the most fabulous and passionate prevention advocates. So we'll talk a little bit more about that as well. So just to review some quick data, and we in prevention, we're anticipating some new data coming out here in the fall on the prevention end of things. You know, when we start to work in behavioral health and those kinds of things, anticipating new data, I think especially after a pandemic can feel a little bit like Christmas time, anticipating what's coming and how it's going to help inform our work. But I think none of us are strangers to, you know, the fact that we have been experiencing a opioid epidemic throughout our country. This is just a quick snapshot of opioid related deaths in Utah. And this gives you a little bit of an idea of what the trends have been. You can see that things have been a little bit on a downward trend, both in terms of prescription opioids and synthetic opioids. That was still the case for 2019, and I haven't seen any data past that. But with a lot of things that we study, of course, these numbers are still too high, and we know that we still have work to do. In terms of neonatal abstinence syndrome and neonatal opioid withdrawal syndrome, just some quick data that I'll let you review here, but certainly, you know, when we look at data, you know, I mentioned that I've done a bit with suicide prevention work, and it was always interesting to me when, you know, we'd get the hard data facts, and I could see that almost 1,000 kids in our area had considered suicide in the last year. That was heartbreaking. But then, you know, when I went to the high schools to teach suicide prevention gatekeeper training, it became a much deeper impact when I was looking at some of those kids in the faces. And sometimes you could even tell who some of those kids were. So all of this data represents, you know, a human struggle, both in mothers and children. And sometimes that struggle can be long lasting. We do know that some of the highest rates were reported among American Indian. You can see the rates there, and it's costly as well, right? You can see in 2016, the NAS and NOWS bursts totaled almost $573 million. So all of this is really important. And what we're going to talk a little bit about today, and again, some of this data is improving. And of course, we have to be careful how we look at data too. For example, our IVUS report showed that in 2019, there were fewer prescription opioid deaths, but we're not sure if that's because people had moved to harder forms, right? Or did they go to treatment and get better? So we have to be open-minded when we're looking at the data too, because positive indicators might be indicating something has either improved or we've got another area that may be struggling more. So our focus today, given kind of the background of what the problem is, and of course, you know, opioids are a problem, but other substances are also problematic. And one of the things I love about talking about upstream prevention is that it has a positive effect on whatever the behavioral issue or negative outcome is. We can have an effect by looking at upstream prevention. So some of you may already be aware of this parable, but I'm going to share it quickly. The parable goes, there's a man and his wife out fishing one day. It's a beautiful day. And as they're fishing in the banks here, they notice a man come floating down the river, struggling for his life, struggling to stay above water. So of course they react to that. They jump in. Wife calls the ambulance while the man pulls this struggling man out of the water, and they connect him with the resources he needs to get some help. And they go back to their fishing, glad that they could do some help. And then over time, this happens again and happens again. And so they end up spending a majority of their time rescuing people from this situation. Well, pretty soon somebody stops and asks the question, what's happening? Why are all of these people falling in and struggling for life? And that's our prevention parable. And that's what we are going to talk a little bit about today. In the parable, let's say that they stopped what they were doing, that they went upstream just above this waterfall and discovered that there was a very slippery and steep rock that as people hiked and peered over, they were falling in. So there could be some really quick fixes for that, right? To help prevent it. Maybe there'd be a sign posted to say, stay off slippery rocks, right? Warning. Or maybe better yet, maybe there's a guardrail that's built to keep people away from that dangerous area. So when we apply this to behavioral health, there are practical ways that we can move upstream where we can ask ourselves, what's really happening here? What's happening in our families? What's happening in our communities? And how can we work to best address some of those issues and prevent them from happening in the first place? This quote comes from the Institute of Medicine. This is kind of a behavioral health Bible, if you will. And I love this quote that's been around for a long time, and it's more true today than ever. And it says, infusing a prevention focus into the public consciousness requires development of shared public vision and attention at a higher level than currently exists. I like to think that we've made some progress since 1994, but this idea of infusing this focus into all domains in our community, I know that there's still work to do, and I appreciate all of your interest and curiosity throughout this presentation to think about what difference could you make in your stewardship, in your domain, in your profession to help these upstream prevention efforts. We know that we've come a long way in prevention. And if we were to just have a discussion, if we had time to have this discussion of things that happened maybe when you were in elementary school or in the history of our country, what kinds of things we know that we've seen. And there's been a lot of approaches. Some of you may remember the Reagan years and sweet Nancy Reagan, this is one of her platforms to just say no, right? And that sounds good, and it's what we all want our kids to do. But the truth is, when they're placed in some of those tricky situations, is it always easy to just say no? Are there underlying factors that made it difficult to impossible for them to say no? So we know that more is needed. And then sometimes, we have thought that approaches to scare the health, pun intended there, scare the health into our kids might be the right approach. If we tell them dramatic war stories about addiction or have people come present at the school about a horrific time that they had because of a substance, or teach them programs in school where we just give them knowledge and pass around different substances and drug paraphernalia to give them the knowledge that they need to make a better choice. But what we know about these strategies that I've just mentioned is that all of those actually increase risk and leave our kids susceptible or more likely to make those choices than not. So thanks to a rigorous field of prevention research and science, we are better informed today than ever on what really does make a difference. So these are 3 pillars that we're going to talk about today. First of all, we want to know what the risk factors are and how to reduce those. Then we want to increase protective factors. And third, implement evidence-based programs and strategies that are going to move both the risk and protective factors in the right direction. And when we talk about risk and protective factors, I often like to compare that to a public health model, right? Because sometimes that feels a little bit vague when we're talking about substance use or behaviors. When we talk about heart attacks or heart disease, for example, if I were to call out, what are risk factors for a heart attack? I'd probably have answers here that indicated a poor diet and lack of exercise, sometimes genetics. I was teaching this class once in person pre-COVID, and somebody yelled from the back of the room to that question, bacon. Bacon's a risk factor, right? So on the contrary side to that, what would be those protective factors? Protective factors would mean maybe we'd put down that bacon stick and pick up a carrot stick, right? That we'd improve our healthy, are you shaking your fingers at that, Kurt? He wants to hang on to his bacon. So we can do things to counter that, get more exercise, right? Eat heart healthy foods. And those would be considered protective and help to buffer against that risk. And those would be evidence-based strategies for heart health, and the same kind of things that can be applied. Specifically, what are we talking about when we say risk factor? So a risk factor is anything that's going to predict the likelihood of drug use, delinquency, school dropout, and really any other pro-social behavior. A protective factor, again, that is going to exert a positive influence and buffers against that risk. So we know that those things are going to reduce the likelihood that a problem will happen. So quick glance, this chart is a result of about 25 years of prevention research. You'll see that across the top there, we have 4 different domains: community, family, school, and then peer and individual. And down the bottom, we have 6 different risk factors listed. And I'm sorry, it's opposite. This chart goes both ways, but we have the risk factors across the top and then the outcomes here towards the bottom. So everywhere where there is a check mark indicates that there have been at least 2 qualitative and longitudinal studies in linking that the risk factor and problem behavior are correlated. So, we could have a full 30-minute or longer discussion about this, but I want to draw your attention to just a couple of things. Look how many check marks are in that family domain. Does it matter what's happening in the family? Definitely does. And also in the school, you can see that almost every check mark is listed there. And by the way, where there's not a check mark, it doesn't necessarily mean that there's no correlation. It may be that the research is still happening or still in development. So on the counter side of that, these are the protective factors that help buffer against that. You can do a quick read through those, but they include cognitive, emotional, social, and behavioral competency, things like self-efficacy, belief in the future, self-determination, pro-social norms and spirituality, and then within the family, school, and community domains, opportunities for positive social involvement, recognition for positive behavior, and our ability to bond with others. By the way, the yellow boxes indicate where these protective factors are correlated with substance abuse as well as depression and anxiety. Risk factors like this, sometimes it helps inform us of where some of the risk factors are shared. And that gets back to that benefit of working upstream, right? And we can implement strategies early. We can work to prevent a multitude of different problems. Okay, quickly, I want to go over this social development strategy. This science right here is one of the reasons that I love prevention science. And there are hundreds, thousands, dare I say, applications for it. I will share a couple of those with you. But Dr. Hawkins and Catalano out of the Social Development Research Group in the University of Washington developed this model. And they did this just with a real curiosity of what drives kids to make the choices that they make. And through this research that they determined, one of the most important things that we have is a healthy goal for our child, that we really understand what are the healthy behaviors that we want to see in our youth. And then that it's really important that we communicate what those healthy beliefs are and those very clear standards, that we are communicating those, and that we're doing that in all of our domains. Parents need to be doing it at home, but when our schools and communities have those clear standards, even better. So then these doctors ask themselves, okay, so if kids have healthy rules and clear standards, do they always adhere to those? If any of us have had any experience parenting or interacting with youth, we know that that's not the case, right? So they wanted to study and say, what makes that difference? And what they found, kind of the magic sauce, if you will, to that is the sense of bonding. When kids have a sense of attachment and commitment and bonding to the people or the institutions or the domains that are setting those healthy beliefs and clear standards for them, they are much more likely to adhere to them. And I love that. I know, like in my experience of parenting, working with youth and talking to other parents, I found it really curious that often in talking to my friends about struggles with their kids, that one parent is really firm on setting clear rules, and we're going to be sticklers and we're going to help our kids understand these rules. And maybe one parent is more like, no, we just need to bond and understand where they're coming from. And they really need a friend through all of this. And a big aha that the social development strategy has given me is that both strategies are needed. If you err too hard on just the rules and enforcing them, what's likely to happen? Kids are likely to rebel, right? And if we swing too far on just the bonding and being our child's friend, then we may see some permissiveness there because there's confusion about what's expected of them. So really, there's a great importance for both healthy beliefs and clear standards, as well as a sense of bonding. Well, what's really cool is this research went even deeper and said, okay, bonding, we all kind of have an intrinsic sense of what that means. It's like the warm fuzzies that we feel with other people, right? But how do we create that? So they actually found that there was a recipe, if you will, for creating this. And anytime that we provide an opportunity to teach skills and then give recognition for that, we are creating a sense of bonding. And of course, in all of that, we understand all human beings are made different. And so we need to nurture individual characteristics in that. This is that same strategy put in a little bit more of a descriptive pictorial way. You can see here in the horizon are the healthy beliefs, and it indicates those same ingredients on the chart. Interestingly, part of the research that helped these doctors come up with the social development strategy was by studying gang behavior. The social development strategy really is gang strategy flipped right side up in a positive way. So let me just kind of illustrate how that is. If we were to say the goal on this would be unhealthy behaviors, do gangs use very clear standards to accomplish that? Absolutely. They have very clear standards, although they're for very unhealthy behavior. Do they incorporate a sense of bonding? Yeah. Yep, that's one of kind of the hallmark things that we understand about gang behavior is that they become incredibly bonded to that gang family, if you will. And how do they do that? By giving opportunities teaching skills, and giving recognition for those things. So kind of interesting insight. So if it works there in a negative way, the science is showing us that when we incorporate those same strategies in a healthy way, they can have an even greater impact. So just a quick story to illustrate the importance of clear standards. When one of my sons was about 5 years old, he was super excited about the opportunity to play t-ball. And he went to practice, he was diligent, and his coach had told him, you know, that he needed to just step up to that tee and hit that ball as hard as he could and run around the bases. Okay, so game time came and my son was so excited to finally be in uniform and hit that ball off the tee. He stepped up to the tee, hit that ball hard, and he took off running. Well, I'm on the sideline and along that first baseline and watching him, and I see that as he's approaching first base, he literally did what his coach said, and he ran around the base. His foot never tagged it. And so, you know, being the mom that I am and wanting him to succeed and not get out, I start yelling from the sideline, touch the base, touch the base. Well, he looked back at me so confused. He got back home. And so I went and found him. I said, you've got to make sure to touch the base the next time you hit. He gets up to bat again when it was his turn, hits that ball, and he wants to please now not just his coach, but his mom. And he runs as hard as he can towards first base, leans down and touches the base with his hand. Okay. And of course, shoots me a look like, are you happy now, mom? Because nobody else is touching the base, right? So in both of these instances, the coach and myself both thought that we were communicating a very clear standard of baseball. But my son, in his very literal mind, did not interpret what we were saying by the fact that he needed to take his foot as he was running and touch the base with his foot. So it's a reminder to all of us when we're dealing with youth that we need to take the time to really communicate the clear standards that we have for our kids. Janelle, how are we doing on time? I just want to do a quick check-in.
You have about 7 minutes.
Okay, great. Another quick story, same child, couple years down the road. We were living down in St. George, close to my parents, and this boy of mine had a problem with being sticky. And every time he was sticky, whether that was eating pancakes or, you know, just dealing with some of the sticky situations of life, he would throw a massive tantrum. Well, my dad didn't know the social development strategy then, but he kind of intrinsically had an idea that incorporated this strategy. So instead of just putting him in timeout or giving him a consequence for this behavior, he said to my son, I want to take you on a grandpa-grandkid activity. And we lived close to some hot pots down there in southern Utah. But before they got to the hot pots, he stopped at the store and they purchased almost every sticky thing they could find. They got soda, they got Hershey syrup, as you can see in this picture here. They got ketchup, they got honey. And when they got to the hot pots, what my dad did was he opened up these sticky things and poured them on his own head and said, sticky is fun. And he kind of modeled this, and my son looked at him with a mouth wide open. And then my dad challenged him, go ahead and try it. We're here around a lot of hot water. You can wash that off whenever you'd like to, but go ahead and try it. And so he practiced feeling sticky and having fun. And he did that by bonding with his grandpa, learning a standard for healthy behavior, that it's okay to be sticky and life can still be fun. So through that, I'll just cap that story by saying, as he got home from that experience and the next time he was sitting up to the breakfast table to pancakes and syrup got on his fingers, he literally stopped, closed his eyes and said, sticky is fun, sticky is fun. Now the son is now 24 years old. He's newly married, they had a preemie baby born this last winter. And he still uses this analogy from grandpa to navigate sticky situations in life. Through COVID, through problems with college and all kinds of things, he has taken this attitude to be a mantra for life, that life can be sticky, but sticky is fun. So again, that's just one example of the social development and strategy where there was a problem, but instead of maybe reacting in normal ways, there was an opportunity to teach a skill and give recognition for that. That was very empowering and life-changing for this young man. I also want to point out that when we're trying to implement this upstream science in our communities, that it's really hard to move alone. It's kind of like pushing a vehicle all by ourselves. But if the more people that are involved, the better, and the more impact, the farther we can get faster. So in prevention work throughout Utah, we have a number of community coalitions. If you go to utahprevention.org, you can actually find out where your local coalition is. I challenge all of you to get in contact with them and see how you can help or be part of it. All of our coalitions work through a strategic planning process, and that this involves assessing local data, seeing where they need to increase in their capacity to make difference, going through a planning process, and then implementing evidence-based programs and strategies, evaluating what they did, how did it work, and then doing the cycle again and again to help improve communities. One other thing I'd like to point out, and I mentioned this just a little bit at the beginning, is that where there has been addiction, there's a great opportunity here to stop the cycle. A lot of times when folks get into trouble, and maybe especially moms that have struggled with addiction, they may have a lot of guilt and shame about their drug use, especially if it has affected their children in negative ways. They can really be passionate about prevention because they want to prevent the cycle from continuing, and for their communities as well. So I really encourage that if you know people that are in recovery, they make super passionate preventionists, especially when they can learn and understand those skills, that it's not always going out and sharing maybe the messy details of their addiction, but that some of the same things that they've learned in recovery, the stress management skills, the anger skills, the decision-making skills, sharing those with people in their influence can go a lot farther than just retelling and regurgitating their story. And once they understand that, they can plug in those skills and really make a difference as well in a super unique and passionate way. Another thing I'd just love to give a plug for is the Know Your Script campaign. This is specific to prescription opioids. And something we'd really like to advocate for through this campaign is that, you know, when we go to a doctor, to be consumers, and I know we've got medical professionals on this as well, and I'm hearing more and more that alternatives to opioids are being discussed. And we know that when folks can have some of these conversations with their doctors, in many cases, it can help prevent an addiction. I guess lastly, I would just like to leave all of you with this quote that I find comfort and inspiration, both amid, you know, some of the heavy heart work that we work with some of these behavioral issues, but also amid the pandemic and all that we're dealing with in our world. But do not be daunted by the enormity of the world's grief. Do justly now, love mercy now, walk humbly now. You are not obligated to complete the work, but neither are you free to abandon it. So again, big thanks to all of you for the great work that you do. I have dropped some references and resources here for your use as well. And happy to take any questions or comments that you have either now, or if you'd like to email me, there's my email address as well. And with that, I'll turn it over to you, Janelle.
Thank you so much. What a great presentation. A couple of things that stuck out to me, and then I'll turn it over to questions, is that I loved your thought about how in early ages we can make a big impact on that social choices that a child or a family is going to make. And last session, Dr. Marcella Smith really talked about that importance in early intervention to kind of look at the mom post childbirth for about a year to think about going back into that addiction world. And so it just is so critical that we continue to normalize those conversations with our doctor, with our early child care providers, and really just as a community to make a bigger impact on it. So that was just a really great insight. So thank you. I'm going to open it up for a few minutes. If anybody has any questions, just go ahead and unmute yourself and ask away or put them in the chat.
There were a couple of citations earlier in your prevalence information. Can you share that if you have them available?
You bet. I will put the link, and in fact, I think it's on the resources page, but I'll drop it here in the chat too, to communities that care. If you're talking about those risk and protective profile charts, you can find those on that website, and that's kind of the hub of all of that research. And I do encourage you, if that was of interest, to go in there and study it a little bit more. What we covered today, we could easily talk about in an 8-hour training, right? And really dive into some of that deeper. So yeah, I'll drop that website in the chat. And if you have questions, feel free to reach out to me. And yeah, Janelle just put in the chat, she'll be sending out the slides as well.
Okay, but the citations for the 2016 1 in 7 births, is that from communities that care?
So that's from the IBIS.
IBIS.
Yeah.
Okay, thank you.
Thank you.
Okay, well, if there are no other questions or comments, I thank you, Heidi, once again for that great presentation. I am going to turn the time over to Sue Olson and Natalie Allen, who are doing the case presentations today. So Heidi.
Okay, and I'm going to go ahead and stop sharing my screen. 1 second.
Perfect. And I know that Natalie joined on, but I also know that she's is in charge of taking care of her little grandbaby. So Sue, I'm not sure if you're going to start it or
no. I can start. The problem is my daughter-in-law apparently has changed her internet access code. So I am doing this from my phone. So, so we'll see how it goes. Let me know if you can't hear me and I'm going to try to be able to see the slides. So I think Sue's going to do slides for me. Is that weird? I don't know. Yeah, here, we'll try.
I think that works good. Now, if I can just get this to work right.
It's all good. Yeah, thank heavens my phone will do this. I kept trying and she's working and I text her and she's not returning. So I don't know the internet code.
Technology. It works really well when it works well and not so
yes.
on the backside.
Okay, can you see the slide presentation now, Janelle?
No,
I can see you, Sue.
You can only see me.
Mm-hmm.
Well, this is where I always run into troubles.
So you click share and then click
so
the
here,
top left hand corner and then there you go. There you go.
From beginning. But it didn't. There. Now do you see the presentation? Yes. Okay, good enough.
We're seeing your.
Yeah, that's
okay.
the problem. So I want to go to there. How about now?
Yep.
All right, we got it. All right, Natalie, you're on.
All right, so this is not an uncommon situation. This is just a recent situation for me, and I thought we would share it today and see what kind of ideas we could come up with. But I'm a nurse practitioner for the Children of Special Health Care Needs Clinic ran by Integrated Services Program, the Utah State Department of Health. And we get referrals from a variety of rural areas. So with that being said, this is a child from a rural area. So Sue, what's the next slide? I don't know. What have we got there? I have no conflict of interest. All right. So this little gal that got referred to me was referred by the primary care doctor to my clinic. The referral was very broad. It said referral for behavior, attention, autism, personality disorder. Like there were 9 things listed on there. Basically, I think that this primary care doc just didn't know where to go and wondered if I could help parse this out. So the history with this child is that the history that I got is from the biological mother. However, this child is a twin. So these are twin little girls, Maddie and Jordan, and they're just over 3 years old. They were removed from their home probably around the age of 4 to 5 months. I'm having a hard time reading this. It's very small. Mom and dad are white, non-Hispanic. Sorry, now I can read it. I pinched it out and it's bigger now. They were removed from their biological mom as infants, and per parent report, it was for malnutrition. I do know that they had been placed in 3 different foster homes before being placed back with their current now biological mother. The foster parent reports that I got were that Maddie was always difficult, even as a very infant, that she was fussy, hard to console. She was more difficult to control and just really didn't like being held. She was just different than her sister. The sisters have now been placed back with their mother, and DCFS is no longer involved. They're done. So I don't really have any assistance from DCFS at this point. The biological dad is incarcerated. I do believe there is a male figure in the house. However, mom is not remarried. Mom could not tell me. She was pretty sure that the girls received early intervention, but that was kind of during COVID. Mom was not involved in the services, so she didn't really know what services were being received. And from my understanding, the transition to school has been rescheduled several times, and the reasons for that are varied. I don't know, who actually really rescheduled it. So mom, when I ask about family history, she tells me, the kids were removed for malnutrition. She does not report that they were exposed to any kind of substance abuse or anything in utero or postnatally. However, in small towns, my care coordinators actually hear things because they're from a very rural town. It has been not officially reported that these girls were exposed to methamphetamines, both prenatally and postnatally. Next slide, Sue. So these are the things that some of the lists that the doctor's concerns were. Mom's concerns when I talked to her is really that there's a constant conflict with mom. From the very moment she wakes up in the morning, mom says from the very get-go, she gets out of bed, she wants Maddie to come to breakfast. She wants Maddie to go to the bathroom, come to breakfast and brush her teeth. And that every day, it doesn't matter what she does, the conflict just starts from the morning time. Next slide. I have met with this family now 3 times. So when we rule out attachment disorder, autism, anxiety, or anything, I feel like I just don't really have a clear history, a real accurate medical history on these girls. The primary care doctor, I inquired if he had any birth any of the birth records, and he doesn't. They've changed primary care doctors. So this primary care doctor doesn't have the original even discharge summary from the NICU. They were C-section, so they spent a few days in the NICU, according to mom, just because they were C-section. That was all that she would really tell me. So I guess what I'm looking for here is how might, so inaccurate information might lead to misdiagnosis. Let me explain that a little bit. So, if we're looking for kids, behavioral problems related to trauma exposure, behavioral problems related to substance abuse exposure in utero, behavior disorders just being removed from 3 foster homes obviously plays a part in all of this, but it would be nice to have the whole picture. I also think it might help as I help this mom's relationship with this little Maddie, if we could really talk about honestly everything that has happened. And I think at this point, I'm not getting the whole story. So I'm wondering if we could have some ideas, if you guys could give us some ideas on how I could get this mom to open up and have some honest conversations with me, helping her not feel like I'm judging her and that I only need to know accurate history so that I can best make a plan for either testing or treatment for these little girls. I also think that when I hear from the mom that the other twin is just fine, I don't think that is entirely true. I think that Maddie just misbehaves, like her behavior is more disruptive. I do see from report that the other child also has attention problems and other issues. She's just a little easier to handle. So I don't think it's a situation of that. It's just one of the twins that is really struggling. Next slide. So here we are. Some questions that we could answer are, how do we help this mom address, be honest? And then the other thing is, if you have some great ideas for what I can share with Maddie and her mom to how to get through the morning without having so much conflict. I did suggest a picture program to use with both of the girls instead of mom like asking Maddie to do anything. If she could have a picture of going to the bathroom, a picture of getting dressed, and there was minimal improvement with the behaviors using that technique. So that's the one thing that I have tried. Do you have any questions about this child now? Because I know it's hard for me. I'm kind of blind. So reading all of this on my phone is challenging.
Natalie, you did a great job. My one question is are you also looking to have some resources of where you might connect this mom with different places as well?
Perfect. Thanks, Janelle. We want to refer them to University Developmental Assessment Center. However, they have an extremely long waiting list. So my point with this child currently is to support them until I can get them into appropriate testing. So I sometimes, if I can help the University Developmental Assessment Center sort of like find the proper pathway, they can sometimes get the testing done sooner. So I am looking to support this family while they are waiting for additional testing or possible diagnosis. Does that help?
Yep, that does. So that would be another thing to kind of talk about in our breakout sessions. The other question that was in the chat is any ideas on how Maddie sleeps?
I wish that my computer were on and I'd pull up the note and tell you exactly, but I do believe she has sleep latency. It's hard for her to fall asleep, but I think once we get her to sleep, she actually does pretty good. My recollection is also she used to have nightmares, but she's not having those. She's not having them as frequent. They're only happening like maybe once, twice a month. But that's a great question. But I do feel like, according to mom, sleep has improved.
Okay. If nobody has any other questions, then we're going to go ahead and do our breakout groups. Hub members, if you'll remember to either take notes or assign someone. The suggestions that Natalie would like feedback on is having those open conversations, helping parents to feel less judged by people when she's seeking support, any resources to connect the family with, and ways to help Maddie get through the morning routine. There is one other question, Natalie, before we break into there from Nancy. It says, are you able to get NICU records?
So excellent question, Nancy. I appreciate that. We have got releases signed. We're trying to get records from both the EI and the NICU. And I don't know how many of you have requested records recently, but it seems to take quite a long time for that to happen. So yes, we requested them, but I have not seen them yet, which is my hopes that I could just like have a real good, honest discussion with mom, but it might take that I need records to help, but that's a great question.
Are they in the Salt Lake area?
They are in Southern Utah area. They're actually in Blanding.
So Janelle, I put the questions from the study in the chat for the facilitators in the breakout room.
I just don't think that the chat moves to the breakout rooms.
I think so, because I think I'm able to see it.
Okay, awesome. So Sue has Adam in there. And then when we also come back to the breakout groups, if we could take a minute to just share one insight from today's session, and there will also be a poll to answer. So I'm going to go ahead and put you guys all in breakout rooms. Oh, awesome. That is so cool. So I had a question for you, Jennifer. Do you have a case of a family that you have from a medical perspective? It doesn't
I mean, we see multiple of them per week. So, you know, I got to like step back and think of what the question would be. But let me try to come up with something.
Okay, that would be great.
Yeah, actually, our faculty who I'm trying to loop into this might be a really good resource for that. I'll see if I can get Kim and Banu involved.
That'd be awesome. I just think that as early intervention and the medical, like getting us to have more of those conversations is so helpful. So
yes,
I would love to see it.
Yes, I'll reach out. Thank you for that invitation.
Okay. And then as everybody else is joining on, I've just put the poll up there. So if you'll take a minute and answer those poll questions. Can you guys all see that? Michelle, you shook your head, so I'm going with that. If you can see it, everybody else can see it.
So I gave bad guidance. Down in the right-hand corner of our meeting, it said leave room. And so I had Lisa and Jennifer and those guys click on that, but you got kicked out of the meeting, didn't you, and had to rejoin? So bad guidance, but there we are.
Well, there you go. It looks like
See there.
we don't have everybody. Or do we have everybody back?
I think everybody's back. We lost a lot during breakout rooms.
Okay, like I said, the poll questions are up. So if everybody would just take a minute to answer those. And then one of the things that as a hub team, we wanted to just take the last 5 minutes instead of asking about what we discussed in our breakout groups. One of the some ideas that you guys liked from this session so that we can share your insights on our social media or with other people that are wondering about the sessions. Does anybody have any topics or anything? Kurt's taking notes on that. How about Nancy? Do you have any insights on today's sessions or?
I actually came in kind of late, but what I did see, I was kind of relating to my granddaughter. I have a granddaughter that's in well, actually I have 2 kids in high school now. But I'm closer to my granddaughter than my grandson. And she's in 10th grade now, and I see some things that have happened in her past in her family. And then things that, you know, with the pandemic last year and not seeing her friend, and then her friend went to Colorado for the summer, and just things that have happened with her that I could see she could easily get into trouble if, you know, the family support isn't there, or if her peer support changes. I just kind of relate things to my kids, my grandkids, as they grow up, and try and find things that I can do to help prevent them from getting into the drugs or alcohol.
Yeah, good insights. Thanks for sharing. Lisa, did you have anything?
Are you talking about what from our group? Sorry, I was typing up my notes, the notes.
No. Oh, sorry. Yeah, just any insight you have about what you learned from today's session, if you're going to use anything from today's session or in your breakout groups, your practice.
For me, it was just a good reminder of what how services are interconnected throughout the state, and how this presentation, this case study is interacts over multiple agencies, and just the importance of us being able to quickly and succinctly communicate with each other, and how this would help this particular case if all the systems were coordinated quicker and easier. This would help this agency meet the needs of this family quicker. But in light of that, we in our group just talked about a bunch of different things. We can talk about that when it's time, but
okay.
Yeah.
Yeah, that was a great insight, Lisa. And I'm going to let Jennifer, Dr. Goldman-Luthi, share the information. She's dropped it into the chat, but kind of looping those services back around. So it's the medical home portal. So.
Yeah, thanks. So the medical home portal is a website that offers guidance for people who work with children with special healthcare needs, particularly healthcare professionals, and then also for families of children with special healthcare needs. And so we have been working to develop a new resource page on NOWS and NAS to go along with this session. And so the link that's in the chat will direct you to a page that gives some general information and then key points from the ECHO sessions and resources that people are suggesting. And if you, make yourself an account and sign in as Utah, you'll see some Utah specific resources as well. Once we get that feature up and going in the next week, it'll be more robust. So we just wanted to get this ready for you guys and say there's another place to get a summary of this information. We hope you make use of it.
Great. There's just so many amazing resources, and we all just have such wealth of information and knowledge to share with everybody, which that's one of the big things I love about ECHO community is you build your community and know that I can call or reach out to Dr. Goldman-Luthi about a question I have. So please utilize the information and the people that are on these calls. We are at time. The case presentation notes, whoever you had, take notes, send those into Project Scope, and we will compile those. They will be on the Canvas site. And then Dr. Goldman, I will also include the medical home portal on our Canvas site, the link to that. Are you also okay if I link that to our website?
Of course, yeah. Happy to share.
Perfect. And then our next session is going to be September 8th. We will be doing the importance of developmental monitoring and implicit bias in dealing with the opioid epidemic. So hope to see you guys then. The survey will go out later today, or at least by Friday. Is that correct, Kurt? Yes.
That's correct.
Okay.
Yes.
And then, as Jared would say, if you want your CMEs, make sure you do that link. Michelle, do you have the code again? It needs to be done at midnight, right?
Yes, and let's see, and the code is, as I have this up here, it's 237195. And Jared did send out a reminder email. So everybody should have that.
Great. And that can be used for a lot of different professions. So go ahead and register for that. Thank you, everybody, and we will see you September 8th.